Hello, I'm going to be speaking about the management of cirrhosis and portal hypertension. I have no disclosures relevant to this presentation. Today, I would like to cover the following things: the natural history and outcome of cirrhosis, the initial management of complications of cirrhosis, some updates and recent studies on management of the complications of cirrhosis, appropriate timing of referral for liver transplantation, and preoperative risk assessment in patients with cirrhosis. We're going to start with patient RS, who is a 52-year-old with alcohol and hepatitis C-related cirrhosis. He has been sober for 5 years. He recently developed ascites and is now on furosemide, spironolactone, and a low-salt diet. His family thinks he is unsafe to drive due to inattention, so he was recently started on lactulose. He comes into the emergency room with diffuse abdominal pain and distension and confusion. While he's being evaluated in the emergency room, his wife asks you how long he can live like this. So if we look at patients with chronic liver disease of any etiology, viral hepatitis, alcohol liver disease, metabolic fatty liver disease, a proportion of these patients over time will develop compensated cirrhosis. As soon as someone develops their first complication of cirrhosis, the most common ones being ascites, jaundice, encephalopathy, or variceal hemorrhage, they are considered to have decompensated cirrhosis. And we know in this case, their liver disease may be responsible for their death. If you follow patients with a new diagnosis of cirrhosis over 10 years, nearly 60% of them will develop decompensation. The most common type of decompensation is development of ascites, followed by jaundice, encephalopathy, and variceal bleeding. Risk factors for hepatic decompensation include GI bleeding, any type of infection, ongoing alcohol use, some medications, dehydration, constipation, obesity. There's a study published in 2011 that shows that as a patient's BMI increases, their risk of hepatic decompensation also significantly increases. Any type of surgery and ongoing viral infection. We are interested in hepatic decompensation because we know it dramatically reduces survival. Here, curve A is a patient with compensated cirrhosis. From the time of diagnosis, their median survival is 9 years. As soon as someone has their first episode of hepatic decompensation, their median survival drops to 1.6 years. We will come back to this because having a patient with decompensated cirrhosis is certainly part of the consideration when we're thinking about liver transplantation, because we know that these patients' life might be limited by their liver disease. We're pretty good at predicting survival in patients with cirrhosis. The MELD score, and this is the initial MELD score, which is the natural log of the bilirubin, INR, and creatinine, is very good at predicting 3-month survival in patients with cirrhosis. Patients are able to be listed for liver transplant with a MELD score of about 15, and patients who are receiving organs in most parts of the country have MELDs between 25 and 35. And as you can see there, their 3-month survival is fairly significantly lowered. We're also good at predicting 1-year survival in patients with cirrhosis, and for this we use the Child-Turco-Pugh score that gives points for amount of encephalopathy and ascites, as well as for lab values, bilirubin, albumin, and INR. A patient with Child's A cirrhosis is a patient with compensated cirrhosis, and they have 100% 1-year survival. A patient with Child C cirrhosis is really quite a decompensated situation, and they have a 45% 1-year survival. So things that I'd like to move on to management considerations in cirrhosis, and this includes preventing and treating complications, determining appropriateness and timing for liver transplantation referral, and preoperative risk assessment in patients with cirrhosis. So we're going to start with ascites. As I mentioned, this is the most common complication of cirrhosis. Patients with cirrhosis will develop portal hypertension, and as soon as they reach a threshold, it's felt that probably 10 millimeters of mercury on a hepatic venous pressure gradient, patients will develop uncomplicated ascites. Eventually, patients will develop ascites and hyponatremia, and a subset will develop refractory ascites. 50% of patients with compensated cirrhosis will develop ascites 10 years from their diagnosis. The development of ascites is associated with a reduction in 5-year survival from 80% to 30%. It's the most common complication of cirrhosis that leads to hospital admission, and any patient with new onset ascites requires a diagnostic paracentesis. At the very least, this should include a cell count and culture to exclude infection, as well as ascites albumin and total protein, and cytology in certain situations. Bleeding complications in patients who require paracentesis is really minimal. And the use of blood products, FFP and platelets for paracentesis is not data supported. There's a large study looking at patients who are getting therapeutic paracentesis, which has a larger bore needle, platelet counts as low as 15,000, INR as high as 8 or 9, and there were no bleeding complications. That being said, many institutions do have some requirements for platelet count and INR, but just to be clear, this is not data supported. A serum ascites albumin gradient of greater than or equal to 1.1 is 97% accurate for ascites from portal hypertension. Also, a high acidic total protein of greater than 2.5 suggests cardiac ascites or a non-portal hypertensive type of ascites. And that is why we, in addition to the cell count and culture, we like to measure those two in any diagnostic paracentesis, and certainly the initial one. So what do we do to treat patients with ascites? If patients are still drinking alcohol, stopping alcohol can really help. The light blue colored recommendations are probably effective in 90% of patients. So a sodium restricted diet of 2 grams per day and education about what that means. If a patient is admitted with ascites, having them see a nutritionist to really go over what that means. Spironolactone 100 milligrams alone may be effective in new ascites. More commonly, we start with dual diuretics, spironolactone and furosemide orally with single daily dosing. We use a ratio of spironolactone 100 milligrams to furosemide 40 milligrams, which allows us to balance sodium, potassium, and you can increase this every 3 to 5 days. Fluid restriction is not really part of the management of ascites. It is more to manage hyponatremia. So fluid restriction is not necessary in the management of ascites unless someone's serum sodium is less than 125. Maximum or high doses of diuretics are spironolactone 400 milligrams and furosemide 160 milligrams. Patients with cirrhosis who are on spironolactone often develop tender gynecomastia, and you can use a miloride or a Plarinone as a substitution in that situation. Because patients with new ascites often have peripheral vasodilation and some lowering of their blood pressure, allowing sort of continued perfusion of the kidneys and managing ascites, it may be worth stopping things like NSAIDs, ACE inhibitors, angiotensin receptor blockers, or propranolol to help perfuse the kidneys and allow for diuresis. Because this is a decompensating event in appropriate patients, liver transplant evaluation is certainly recommended or considered. And I just wanted to draw attention to a couple of studies that were done and published in 2018, which was looking at patients with cirrhosis and ascites and giving them albumin infusions. These were not patients who had refractory ascites or were getting large volume paracentesis. They were on diuretics for their ascites and getting an albumin infusion once per week. The ANSWER study really showed a benefit to this in terms of reduction of acute kidney injury and hospitalization, whereas the MAC-TH study did not. This is not standard of care, but I think probably, so giving albumin infusions to patients as part of management of cirrhosis and ascites in the absence of large volume paracentesis and refractory ascites is not standard of care, though I think this will continue to be looked at. Over the last few months, RS has been unable to receive diuretics due to hyponatremia. What are other management steps that might be considered for his ascites? Number 1, TIPS. Number 2, large volume paracentesis with albumin repletion. Number 3, liberalizing his 2 gram per day sodium diet. Number 4, urgent liver transplant listing. Refractory ascites gives extra listing points. And 5, increasing his non-selective beta blocker. Here the answer is both 1 and 2. Just to cover the other ones, sodium restriction or 2,000 milligrams of sodium per day is very helpful in management of ascites. So certainly liberalizing that will not help. There are no special points for refractory ascites in liver transplant listing. And I think increasing a non-selective beta blocker may cause worsening hypotension and or decreased renal perfusion, which will probably not help either. So management of refractory ascites, about 10% of patients with cirrhosis with ascites, they will develop refractory ascites. And the definition is really unresponsiveness to a 2-gram sodium diet and high-dose diuretics, or clinically significant complications of the diuretics, the most common ones being encephalopathy, elevated creatinine, hyponatremia, and hyperkalemia. For these patients, probably diuretics are not going to be able to be used, so we consider things like serial large volume paracentesis or TIPS as a bridge to liver transplantation. We know that if patients are receiving large volume paracentesis of at least 5 liters, it is recommended that they receive albumin infusions of 6 to 8 grams per liter removed. This has been shown to improve survival and prevent what's called post-paracentesis circulatory dysfunction, which can certainly lead to acute kidney injury and or hepatorenal syndrome. The other thing we know is non-selective beta blockers in refractory ascites has conflicting data. But if patients have a persistent systolic blood pressure of less than 90 millimeters of mercury or acute kidney injury, they should probably not be on a beta blocker in the short term or long term. So tips for refractory ascites. There is a survival advantage with tips in patients with refractory ascites in several recent meta-analyses. TIPS causes a gradual suppression of neurohormonal vasoconstrictors over 4 to 6 months, so it's not an immediate fix. By 6 months, about 80% of patients will clear their ascites. It requires very careful patient selection, a MELD score of at least 18, and the MELD score was initially developed to determine who would do well following a TIPS, who would survive following a TIPS. Patients with a MELD greater than 18, patients who have hepatic encephalopathy at baseline, who are advanced age, who have cardiopulmonary insufficiency and sarcopenia are at greater risk of complications post-TIPS. There are a number of studies published recently that shows TIPS stents with smaller diameters, 8 to 10 millimeters, have been equally effective in ascites management, and they reduce the risk of hepatic encephalopathy. So RS has an admission sodium of 121, a creatinine of 2.1, which is considered acute kidney injury based on his baseline, and evidence of spontaneous bacterial peritonitis on diagnostic tab. In addition to starting ceftriaxone, your next steps in management should include number 1, stop nadolol, number 2, albumin infusion, number 3, check urinalysis, number 4, start pentoxifylline, and number 5, 1, 2, and 3. Here the answer is 1, 2, and 3. So moving on, it took me a while in my liver training to understand that hepatorenal syndrome was really part of a spectrum of ascites in patients with cirrhosis. So we just discussed refractory ascites, and I think moving forward with that, a proportion of these patients will have, at the time that they're diagnosed with refractory ascites, or will soon develop hepatorenal syndrome. So the clinical features of hepatorenal syndrome, you must have cirrhosis, you must have ascites. You have a diagnosis of acute kidney injury according to the International Club of Ascites Acute Kidney Injury criteria. No creatinine improvement after 2 days of diuretic withdrawal, and no creatinine improvement after 2 days of volume expansion with albumin. Patients must have an absence of shock or nephrotoxin, and if a urine sediment is checked, which it's recommended that it is, no signs of structural kidney injury. There traditionally was incorporation of urine sodium levels in the definition of hepatorenal syndrome. Please note that that is no longer part of the overall clinical features or definition. So here is the natural history of hepatorenal syndrome, and this is something important to keep in mind, I think, in managing patients. So type 2 hepatorenal syndrome, these are patients with refractory ascites. They have a creatinine that's elevated above baseline. and probably are limited in their ability to use diuretics, so they're receiving therapeutic paracentesis. So their biggest issue in type 2 hepatorenal syndrome is often refractory ascites. Most commonly, the transition from type 2 hepatorenal syndrome to what is now called HRS-AKI, or is previously called type 1 hepatorenal syndrome, is some sort of insult to the kidneys. Most common is an infection. Most common infection is SBP, as you see here, and as has happened in our patient. But things like a surgery, massive GI bleed, et cetera, anything that probably insults the kidney, hypoperfuses the kidney for a brief time, you see a rapid rise in creatinine and oliguria. How do we manage hepatorenal syndrome? If a patient has an underlying liver disease that could require treatment, such as alcoholic hepatitis or hepatitis B, treating that can be helpful. In patients with SBP, where we're worried about this transition from type 2 hepatorenal syndrome to HRS-AKI, giving albumin infusion to perfuse the kidneys is important. Also, there's data to show that in that situation, stopping non-selective beta blockers, again, as a roundabout way to ensure more perfusion of the kidneys, has been shown to be of benefit. Treating with a vasoconstrictor drug in combination with albumin. So after a patient has been declared as to having hepatorenal syndrome, with a withdrawal of diuretics and 2 days of albumin infusion, starting a vasoconstrictor can be helpful. So the most helpful is terlipressin plus albumin. Terlipressin was FDA approved in the US in September of 2022. Norepinephrine and albumin, which obviously has to be given in an intensive care unit, is equally effective to terlipressin. What we more traditionally use is albumin, octreotide, and midodrine, which is probably the least effective of these three. Fortunately now, terlipressin can be used on a cardiac monitor on most floors and doesn't require an intensive care unit. Hemodialysis can be a bridge to liver recovery or transplant, and liver transplantation, obviously, this is certainly a decompensating event with a significant mortality, particularly as patients develop HRS-AKI, rapid rise in creatinine, and oliguria. So just a few words on spontaneous bacterial peritonitis. Obviously, any patient with ascites is at risk of this, and just to remind people that it is a really significant trigger to hepatorenal syndrome and HRS-AKI. These patients require systemic antibiotics for community-acquired SBP, ones that we know can penetrate the peritoneum, so ceftriaxone or cefotaxime. Aminoglycosides are probably effective, but because of the concern for acute kidney injury and HRS, should be avoided if possible. Most patients will respond to a 5-day course of treatment. There are no specific guidelines on whether to do a retap. I would say if patients are not responding clinically, meaning creatinine's not improving, other features of their decompensation are not improving, it might make sense to tap again, do a diagnostic tap again to make sure the antibiotics chosen is being effective. If patients continue to improve on a 5-day course of treatment, that's probably fine to not necessary for a re-diagnostic paracentesis. Cessation of non-selective beta blockers has been shown to improve survival in patients with SBP, again, for perfusing the kidneys. And there's data to show that giving albumin infusions on day 1 and day 3, particularly if patients have an elevated creatinine, elevated serum bilirubin, or elevated BUN, can improve survival. A few words on primary and secondary prophylaxis. Any patient who is with cirrhosis who is hospitalized with any type of GI bleeding should receive primary prophylaxis. Any patient with ascites total protein of less than 1.5 and either renal failure or liver failure should receive primary prophylaxis. Patient with prior history of SBP should receive secondary prophylaxis. The two most common medications that we use are trimethoprim sulfa daily and ciprofloxacin daily. There are studies looking at intermittent or weekly doses of antibiotics. These are thought to be potentially inferior to daily dosing, though they do prevent, help with prophylaxis over placebo because of the development of resistance. RS is being treated for SBP, but his encephalopathy persists. Lactulose was held on admission due to concern for intravascular volume depletion. Other potential treatment options for encephalopathy include number 1, hemodialysis, number 2, rifaximin, number 3, 4 liters of polyethylene glycol or Golightly, number 4, neomycin, and number 5, protein restriction. Here, the best choice is rifaximin. This is very effective in treating acute hepatic encephalopathy, and there is no concern for causing diarrhea. Hemodialysis can help a little bit with ammonia levels, but is not a very effective management when there's a medication that someone can take. Interestingly, both Golightly preparation and neomycin are effective in treating acute hepatic encephalopathy. I think having a very encephalopathic person take a Golightly colon prec would require an NG tube, so probably not first line if you have something else. Neomycin, also effective in acute hepatic encephalopathy, but it has a kidney toxicity, so probably not the best in this patient. And there is no data to support protein restriction is actually helping with the management of acute hepatic encephalopathy. So how do we treat hepatic encephalopathy? Often there is a precipitant, and if we can figure out what that is and treat that, that can be extremely helpful. Most common precipitants are infection of any type, electrolyte abnormalities, any type of GI bleeding, constipation or dehydration, and the use of sedatives. Your goal is really to lower the ammonia level. If patients are able to take it, lactulose, aiming for 2 to 4 bowel movements per day is initial first-line therapy, with the addition or transition to rifaximin. More bowel movements is not necessarily better and can again contribute to dehydration or electrolyte abnormalities. So really titrating to 2 to 4 bowel movements a day is the goal. And these are loose bowel movements. Do not restrict protein. Patients with decompensated cirrhosis have sarcopenia. It's a catabolic process, so they really need to maintain a dietary protein intake of 1.2 to 1.5 grams per kilogram per day. Once you've established that someone has hepatic encephalopathy and an elevated ammonia level, it's better or preferred to use the physical and neurologic exam rather than serial blood ammonia levels, as I think these are more sensitive to whether your treatment is working. On day 2, RS has massive hematemesis. He has an urgent endoscopy that shows grade 3 esophageal varices with red whale signs. He has 3 bands placed. Next step should include all of the following, except octreotide IV for 72 hours, consider TIPS if he rebleeds, transfuse to keep hemoglobin greater than 10, continue ceftriaxone treatment for SBP. The exception, the one that is not correct, is transfuse to keep hemoglobin greater than 10. So management of acute bleeding in patients with cirrhosis depends on location, severity, and degree of hemostatic impairment. For variceal bleeding, the major cause is increased portal pressure rather than a bleeding diathesis. For non-variceal bleeding, you more want to focus on the bleeding diathesis, managing the INR platelet count and fibrinogen level. Vitamin K, usually IV, keeping a platelet count greater than 50,000, administering a source of fibrinogen to get a level greater than 100 to 120, and considering an antifibrinolytic. Thrombopoietin receptor agonists are quite effective at increasing platelet count in patients with cirrhosis and have been FDA approved for this, but they take 5 to 7 days, so they're not effective in acute bleeding. Management of acute variceal hemorrhage, these patients should be in an intensive care unit and receive an upper endoscopy within 12 hours. A restrictive blood volume resuscitation protocol is recommended, initiating transfusion at a hemoglobin of 7 and maintaining hemoglobin at 7 to 9. It's felt that over-transfusing can increase portal pressures and cause continued bleeding. These patients should receive short-term antibiotic prophylaxis. IV ceftriaxone is the antibiotic of choice. And they should receive a vasoactive medication, octreotide, somatostatin, or terlipressin for 2 to 5 days with a transition to a non-selective beta blocker. There are a number of studies looking at TIPS in patients with child C cirrhosis or child's B cirrhosis with active bleeding. I'm going to talk about one of the initial studies of this, though there have been more recently that have borne out. Here's a picture of some large esophageal varices and one that's been banded. So just a few words on TIPS. This stands for transjugular intrahepatic portosystemic shunt. It's placed through the internal jugular vein, fed down the IVC into one of the branches of the hepatic vein, a shunt through the liver that connects with one of the branches of the portal vein and allows smoother blood flow to flow forward rather than backwards into the collaterals, particularly around the stomach and esophagus. One of the first studies looking at this in 2010 was published in the New England Journal of Medicine. It looked at early TIPS as an option for variceal hemorrhage. It took patients with Child's B and C cirrhosis, so they were decompensated with acute variceal bleeding. They all received vasoactive drugs and endoscopic therapy, and then they were randomized. Despite the fact that their initial bleeding was under control, half of them underwent a TIPS, and the other half continued on what we tend to do, or we see more commonly in the hospital. Continued vasoactive drugs for 3 to 5 days, a transition to a non-selective beta blocker, and continued banding to obliteration. Of the second group, 7 needed a rescue TIPS while they were in the hospital. The median follow-up was 16 months. At 1 year, the episodes of encephalopathy, which you might have been worried about more in the TIPS group, was really statistically insignificant, and there were no significant differences in adverse events overall. The most striking thing about this is here. So looking at the early TIPS group versus the more conservative management, freedom from rebleeding. So nearly everyone who had an early TIPS had no further bleeding versus half of the other group had rebleeding over 2 years. And also survival was much improved, partly because of the reduction in rebleeding, but 86% of patients survived at 2 years who had the TIPS and 61 without. This is one of the early and sort of simplest studies, but there have been a number of studies that have repeated this data with similar results. And also there's a number of studies looking at why, despite this amazing data, a lot of centers aren't doing that. And that's probably the biggest question now. I think it's worthwhile considering this and thinking about TIPS in this population. So if the endoscopy on RS showed an isolated bleeding gastric varix, what would your treatment options include? Number 1, consulting vascular radiology for a TIPS. Number 2, consulting vascular radiology for a BRTO. Number 3, cyanoacrylate glue injection. Number 4, continue IV octreotide and proceed with urgent transplant evaluation. And number 5, 1, 2, and 3. Here the answer is 1, 2, and 3. Management of bleeding gastric varices, initially you want to do the same things you would do for esophageal varices: vasoactive drugs, a restrictive transfusion protocol, and antibiotic prophylaxis. As many of you know, banding gastric varices can be technically more difficult than banding esophageal varices, particularly the further away they get from the GE junction. So studies are things that you can use for these larger gastric varices: cyanoacrylate glue injection. Here you basically put a needle into the varix and inject this glue. It polymerizes into a firm clot within the varix. There is a risk of distal embolization, and interestingly, it's not approved by the FDA for use in the US for this indication. There's center-dependent expertise. TIPS, which universally lowers portal pressures, is very effective for managing bleeding gastric varices. There are also more localized techniques. So the balloon-occluded retrograde obliteration, BRTO, also done by vascular radiology. Here they rely on the fact that a number of patients with gastric varices have spontaneous renogastric shunts. So they do imaging and find a renogastric shunt, then they introduce a balloon catheter through one of the renal veins directly into a draining vessel and instill a sclerosant or sponge. This has 90% long-term bleeding control. The issue with this is because it's localized and closing a spontaneous shunt, it can increase portal pressure in other locations. So if a patient has both bleeding gastric varices and large esophageal varices, this may not be the option. You might want to go back to a TIPS, which will globally decrease portal pressures. This can also cause development of ascites in certain patients. And again, center dependent. There is a number of centers that do endoscopic ultrasound guided coiling of gastric varices through the esophagus, which can be very effective, and again, a more localized approach. So this is probably the newest data and most interesting data that's come in the last 6 to 12 months in terms of management of gastroesophageal varices. So we know that varices are present in 50% of patients with cirrhosis, 30 to 40% of compensated patients, 85% of decompensated patients, and they develop in patients with compensated cirrhosis at a rate of 7 to 8% per year. There's been a lot of looking at ways to predict clinically significant portal hypertension, which is defined as a hepatic venous pressure gradient of at least 10 millimeters of mercury. And basically, if you have presence of clinical decompensation, so development of ascites, bleeding, et cetera, you have varices on endoscopy. If you have imaging that shows portosystemic collaterals or hepatofugal flow in the portal vein, this can be considered clinically significant portal hypertension. But guidelines that came out from the AASLD and were published in Hepatology in May of 2024 show that you can also diagnose clinically significant portal hypertension with elastography, usually a FibroScan, and a platelet count. And here, if you have a liver stiffness of 15 to 20, and a platelet count of less than 110, this is considered clinically significant portal hypertension. If you have a liver stiffness alone of greater than 25, this is considered clinically significant portal hypertension. And what they have found is mapping these out, patients with liver stiffness, rising liver stiffness and lower platelet count also have a specific risk of hepatic decompensation, which we know is related to their portal pressures. So the guidelines now for management of esophageal varices, if you have a new diagnosis of cirrhosis, the recommendation previously was to get an endoscopy to screen for esophageal varices. Now you can also use an ultrasound, elastography, and platelet count to assess for clinically significant portal hypertension. If a patient has varices on the initial endoscopy or clinically significant portal hypertension by elastography and platelet count, the recommendation is to start carvedilol 6.25 daily and increase to 12.5 daily if tolerated. There are no guidelines about monitoring heart rate or blood pressure. The feeling is that this lowers portal pressures enough that we don't need to worry about it once we can start. And if you can get a patient to 12.5 milligrams daily of carvedilol, either separated over 6.25 BID or 12.5 once per day, they're probably having satisfactory lowering of their portal pressures. If there's no varices on the original endoscopy, repeat every 2 years. If patients have ongoing liver injury, they're still overweight or they're still using alcohol, or every 3 years if they have more stable liver disease, abstinence from alcohol, viral elimination. Or now you could repeat the elastography and platelet count annually, which is less invasive testing. There is still a recommendation to do an endoscopy at a time of any clinical decompensation, but you can also probably assume these patients have clinically significant portal hypertension and consider introduction of carvedilol. So in patients who have cirrhosis, but they do not have varices on endoscopy, and they do not meet the definition of clinically significant portal hypertension by elastography, the goal there is really to prevent clinical decompensation. It is not recommended to start a non-selective beta blocker in these patients. Grade 1 varices, non-selective beta blocker, carvedilol preferred, and if tolerated, no need to repeat EGD. Again, here you're assuming that, that you are adequately treating the clinically significant portal hypertension. Patients with grade 2 or 3 varices, if they have an endoscopy, non-selective beta blocker or variceal ligation is recommended. So RS is slowly recovering from SBP and his variceal bleed. He continues on IV ceftriaxone for 5 days and then transitions to ciprofloxacin for secondary prophylaxis. His creatinine slowly normalizes. He transitions from IV octreotide, and there's a debate about restarting nadolol given his refractory ascites, sort of low blood pressures. His encephalopathy improves with initiation of rifaximin and improvement in SBP and hyponatremia, and his MELD is 19. His wife asks you what else can be done. And here the question is, does he need a liver transplantation? Patients should be referred for liver transplantation if they have episode of a clinical decompensation. RS has had many. But here, again, going back to our initial slides, we know that patients, as they have decompensation, their life may be limited by their liver disease, and they need a biochemical decompensation. So they need a MELD score of at least 15. Here are the most common ways patients decompensate. Hepatocellular carcinoma that's confined to the liver is considered decompensation, so a reason for liver transplant referral. Other considerations for liver transplantation, which are separate, are acute liver failure, severe alcoholic hepatitis, and poor quality of life or recurrent resistant infections in patients with PSC or polycystic liver disease. So what is the MELD score? It stands for the Model for End-Stage Liver Disease. It was originally created to predict short-term mortality post-TIPS. It's been the basis of liver allocation in the US since 2002. And in 2016, we started using the MELD sodium, and more recently in July of 2023, we started using the MELD 3.0. There's been continued efforts to try and really predict mortality in patients with cirrhosis, so we're assured of fair organ allocation. So currently the MELD 3.0 includes 5 objective lab tests: sodium, total bilirubin, creatinine, INR, and albumin, and there's also points for gender. It's highly predictive of 3-month mortality in patients with cirrhosis, and a MELD of 15 is a survival threshold. So where a patient will survive, their MELD is greater than 15, their patient will survive longer with a transplant than without. So if you look at the different etiologies of adult transplant recipients in the US over the last 5 or 6 years, this has really changed, both because we've learned to treat hepatitis C, but also because of a rise in alcoholic liver disease. And here, other is metabolic fatty liver disease. And these are the 2 most common indications for liver transplantation in the US. Exclusions for liver transplant include a MELD score of less than 15, no survival benefit, severe cardiac or pulmonary disease. So these patients have to have a sick liver and an otherwise pretty healthy body to allow them to survive a large surgery. AIDS, patients with HIV can receive transplant, but AIDS is usually a contraindication. Ongoing alcohol or illicit substance abuse, liver cancer with metastatic spread, uncontrolled sepsis, and anatomic abnormality that precludes liver transplant. Most centers do not do liver transplant for intrahepatic cholangiocarcinoma or extrahepatic malignancy unless it's very remote with a limited risk of recurrence. Persistent noncompliance or lack of an adequate social support system. So RS is listed for liver transplantation with a MELD of 19. His family wants to know how long until he gets a deceased donor liver transplant and what can he do to increase his chances of receiving a transplant. So liver transplantation in the US, the country is divided into 11 regions. If an organ becomes available in that region, it will go to a person on the list in that region. As you can see, there's marked variability across the country in terms of number of liver transplants available in each of these regions. And this has a significant effect. It means patients get sicker. They're more likely to die on a waiting list in somewhere like Region 1, where we are, where there's 454 as opposed to 1818. So they get transplanted at higher MELDs, which means their likelihood of dying on the transplant list is higher, and probably they're more at risk for poor post-transplant outcomes. If insurance allows, patients are allowed to travel to different parts of the country. They can also discuss receiving high-risk organs within their region to increase their chances. And there's also living donor transplant. 6% of liver transplants in the US in 2023, patients must be listed for deceased donor transplant. These are patients that have an anticipated prolonged time on the wait list. They're usually less sick, MELD of 15 to 20. And because they're taking 2/3 of a liver from a healthy person, they're not getting a full liver, they're getting 2/3, the right lobe usually, and an adult pediatric cases get the left lobe of the liver. So this is an option in centers that are comfortable with doing this. RS has multiple emergency room visits for protuberant and painful umbilical hernia and concern for hernia incarceration. His MELD remains 19 to 20. General surgery recommends hernia repair. General surgery requests preoperative hepatology clearance. RS has a risk of perioperative mortality at 30 days following elective hernia repair closest to 1%, 10%, 30%, or 80%. Here the answer is 30%. So surgical risk in patients with cirrhosis, we can use the Child-Turco-Pugh score or the MELD score. Most of the Child-Turco-Pugh studies were from cardiac or abdominal surgical literature, and essentially a patient with Child's A cirrhosis, a compensated patient with cirrhosis has a 10% risk of mortality following a large surgery. Child C cirrhosis has an 80% risk of mortality after a large cardiac or abdominal surgery. A Mayo study published in 2007 looked at preoperative MELD score, age, ASA class, and a number of patients with cirrhosis undergoing a wider variety of surgeries. So there were certainly cardiac and abdominal surgeries, but there were also orthopedic surgeries, things like laparoscopic cholecystectomy. And they basically found that the MELD was the best predictor of 30-day and 90-day mortality. Here you can see the 30-day mortality. So a MELD of 12 to 15 has a 25% 30-day mortality following a surgery. More recently, the Vocal Pen score looks at a number of factors in terms of predicting different surgeries, surgical risk in these patients, and I'm going to show you an example. So here is looking at the preoperative MELD. Our patient has a MELD of 19, so you can see his 30-day mortality and his 90-day mortality is even higher than 30%. And the Vocal Pen score, you can look this up, Vocal Pen score, and put in age, albumin, total bilirubin, platelet count, BMI, whether the patient has metabolic fatty liver disease, what their ASA score is, whether this is an emergent surgery, and what type of surgery, and it will give you 30-day mortality, 90-day mortality, as well as a risk at 90 days of hepatic decompensation. And I put in numbers to sort of show you what RS would have. What this usually means is in a patient with decompensated cirrhosis, elective surgeries are recommended to be postponed until after liver transplantation. So in summary, hepatic decompensation reduces survival. The MELD and Child-Turco-Pugh scores predict 3-month and 1-year mortality in patients with cirrhosis. TIPS is probably better than large volume paracentesis and management of refractory ascites in select patients. Prevention of HRS includes antibiotics and upper GI bleeding and IV albumin in spontaneous bacterial peritonitis and large volume paracentesis. Please consider stopping non-selective beta blockers and SBP to protect fragile kidney function. Consider early TIPS in Child's B and C variceal bleeds. Gastric varices have a broader armamentarium of local management cyanoacrylate glue, TIPS, BRTO, or EUS coiling. Refer for liver transplantation when a MELD is at least 15 and there's signs of clinical decompensation. And consider the Child-Turco-Pugh score, the MELD score, and the Vocal Pen score if you're asked to estimate surgical risk in patients with cirrhosis. Include a number of references here that were discussed today. Thank you for your attention.